Happy New Year, everybody. This is Franklin Walker with the North Carolina Medical Society, and I am the host today of the first Power Hour for 2021. I think we're going to have a very interesting discussion today about the COVID vaccine and minority communities and how that vaccine is being rolled out and some of the distrust that goes with that vaccine. So before I get into my questions, I want to introduce our panelists today. First of all is Dr. Karen Smith, who's a family physician in Raeford, North Carolina. Dr. Bryant Murphy, who is an anesthesiologist at UNC Chapel Hill. He is also the president of North Carolina Medical Board. Artina Dawkins, who is a PhD with the Wake Forest University School of Medicine and Wake Forest Baptist. Dr. Chamaine Brooks-Locklear, who is a family physician in Pembroke, North Carolina. Welcome to everybody, and again, Happy New Year to you guys. So with that, I want to jump right in a little preamble here. We know that minority groups continue to be hit the hardest by the pandemic in 2020, and all populations of color experience higher nationwide death rates than white Americans, with Indigenous, Black, and Latino Americans at least 2.7 times higher than their white neighbor. However, with a vaccine now being administered, there is hope the end of the pandemic is in sight. However, a recent journal of the Community Health found that vaccine hesitancies was high among African Americans, Hispanics, and other folks. There are two challenges now at stake here. One is how this vaccine is being administered, and the second one is the mistrust around or the distrust around the vaccine among certain populations. So the first topic I'd like to discuss with the guest is how are the allocations administered in your prospective organizations, and what has worked and what challenges are you experiencing, okay? So, Dr. Smith, I'd like to start with you, if I might, please.
Thank you, and it's a pleasure to participate in today's discussion. It is such an important topic. In regard to access to the COVID-19 vaccine, we have had a very interesting experience, shall I say. I am an independent private physician, rural solo, Hope County, North Carolina. And when we discovered that we were actually in the 1A category, and that was determined by going on to the Department of Health and Human Services site, the CVMS, and registering, and it said, you are 1A, contact your local provider and get the vaccine. And I did that. I called the local hospital system, and the response that I received was, you can get the vaccine after the emergency room physician, the ICU physician, emergency room nurses, and on and on and on down the list. I later then received correspondence stating, because you are a community provider and you're not a full-time employee of the staff at the hospital, we will not be able to administer your vaccine. I contacted another hospital system and I said, I'm 1A, I'm ready for my COVID-19 vaccine. We were told, we're not quite sure how, but in the 11th hour on December 22nd, we were told, be at the hospital at 6 a.m. and you and your team can get the vaccine. So we woke up early in the morning, knowing we couldn't get on the road that late, early because of the governor's driving restrictions, and be home between 10 and 5 a.m. We made it to the hospital. We received our vaccine, myself and the entire team. And I can tell you, it was a gracious experience. I know what I went through, but I'm also told that several of my colleagues have gone through the same thing. I'm even told that some of our colleagues who are actually employees of the hospital are told, because they are in a community setting and not in the immediate emergency room or ICU, that they will be getting their vaccines at a later time. And this issue was highlighted throughout the state through the medical society and our associations, and word was sent out to our secretary, who has now launched some new provisions. But I'll stop there. But I will say it was a little disheartening to know that we were kind of on the bottom of the list. And let me say this, I even spoke with a couple of my patients who are doing janitorial and custodial services at the hospital. And they were told because they were subcontracted that they're not even on the list. So we have to figure out a different way.
Okay, super. Dr. Brooks-Locklear, can you tell us how it's going down in your neck of the woods, please?
Yes, so I work at Pembroke Family Practice in Pembroke, North Carolina, and I happen to be an employed physician through the hospital system, Scotland Memorial Hospital or Scotland Healthcare. So I'm employed and not private practice. And so I'm already able to get the vaccine. I already started booking appointments for folks before we even had the vaccine. But I found that it was very easy for me to get the vaccine because I kept hounding them about, I want to get it. And I was actually able to get my vaccine the very first day my hospital had the allotment in. They did surveys the 2 weeks before at my hospital system and discovered that amongst the medical staff, it was very high interest. It was over 90% that planned to get the vaccine. However, amongst the other employees, especially the nursing staff and other hospital staff, it was very low because they knew they only had 500 allotments of the vaccine. They knew they couldn't vaccinate everyone if everyone was interested, but unfortunately, the interested numbers were pretty low. So the people in the offices were able to get it just like our hospitalists and the ED staff. All 4 physicians in my office got it within about a week of each other. Unfortunately, it's been 3 weeks now and nobody else in our office, the nurses, the clerical staff have not had their vaccine due to vaccine hesitancy. They're just a little on the fence about it. But all physicians have been able within my network to get it. However, I do have friends who are, for instance, private practice like Dr. Smith in the area in Robeson County. And it took them a couple of weeks because they were not directly associated with the hospital. They had to go, even through the Robeson County Health Department, they had a lot of trouble. Some had to go to an outside hospital about an hour away to actually get it. But finally, most of my physician friends in the region who are private do have access, and some of their staff has started to get it. So it wasn't a smooth rollout for them, but it's starting.
Super. Dr. Murphy, will you tell us how things are going at UNC, please, sir?
Sure, and again, thanks for the opportunity and invitation to come and participate in the panel today. Our experience has been a little bit different. Obviously, at a big academic medical center, we were able to, get our allotment and get people vaccinated. And I'm actually on the way to get my second dose today, so things have been working out okay from that standpoint. The biggest issue that we have been having is just some logistical challenges with trying to figure out exactly who should be in line and at exactly what time. You can imagine with an institution with this many people, having thousands of people on the 1A list creates a little bit of a logistical challenge. And so, being the anesthesiologist, we, are kind of there on the front lines. And so it was even kind of segmenting that 1A list into who really needs to be, I guess, the first 1A versus the second, and kind of going back and forth with the state to kind of get the real 1A list put in there. So a lot of our challenges have been logistical, but at least as of the last count, the majority of the people on that 1A list who wanted the vaccine were able to get it through the first round, and we're actually starting the second round now. So I think we've learned some lessons day by day, and hopefully these logistical challenges will be a little bit better for the second dose than they were for their first dose.
Sure. I want to, as a follow-up question, Dr. Murphy, within UNC Healthcare, which of course is a vast organization, are there pockets or folks that are resistant to getting this vaccine? And is UNC adopting a policy to address that? State and federal employees, I think there can be a mandate. I didn't know if UNC as a healthcare system was getting to that point.
No, there's not a mandate, at least not currently. And there are pockets of people who are a little bit resistant. Some of it is education. Some of it is distrust, as we are discussing. Some of it is frustration with the way that the rollout has been. But currently, there's not a mandate that everyone has a vaccine.
Super. Dr. Smith, while I've got you up there and I'm thinking about this question, you've got a small private practice. if you have people within your practice that are resistant to that, how have you dealt with that?
Well, we did have 2 individuals who were resistant to the vaccine. And we dealt with it the same way that we dealt with our patients. What words can I say that will convince you to get the vaccine? What is that 2-minute, let me give you all the information so that you will trust the validity of the vaccine, recognizing, yes, it was rolled out quickly, but it's to save your life. And we use those individuals and really kind of rehearse that argument with them. And now they've received their vaccine. So we're fortunate in that our entire staff has been vaccinated.
Excellent. Before we move on to the next topic, I do want to talk about the guidelines that are being used across the country and for the most part in North Carolina from the CDC. And we've talked a little bit about this. There's the 1A group and then the 1B, 2, 3, and 4 with the frontline healthcare workers and residents of nursing homes, long-term care facilities being those recipients in 1A, right? So we've been doing this now, gosh, almost a month, right? As you guys have an opportunity to look at what those guidelines are, do you see some gaps there that we can fix? And do you think since the virus has spread along the fault lines of social inequality, maybe there needs to be allocation based on social vulnerability? And Dr. Smith, I'm going to start right there with you since you're already there.
That is an interesting question, whether we should be looking at it based upon vulnerability. And I see that the CDC has attempted to do that. But I also understand the need for vaccinating the healthcare workers who are trying to provide care to people who are presenting with COVID-19. Our local hospital system, we are seeing an average of 2 deaths per day. One day we had 4 deaths for COVID-19, but we're also seeing a tremendous number of hospital and local physician offices who have employees who are getting exposed and they're having to leave their positions. And so that's creating a workforce shortage for us. Mm-hmm. And so we have to have ample enough of providers of care in order to take care of the people who are presenting. We know we can't roll everybody into getting vaccinated at one time. So we just have to go and deal with the compromise that has been made, making sure that we do have a sufficient supply of providers of care and then roll it out according to the ages and the vulnerability as CDC has done. I don't have any disagreements. I know it's not the best, but it allows us to get the vaccine where it needs to go.
Right, thank you. Dr. Brooks-Locklear, I want to come to that question with you. And again, I know you're an employed physician, but your take's going to be a little bit different than maybe Dr. Smith's.
Yeah, I do agree with you. Agree with her. I think the CDC plans are pretty good, and I think it's essential to get all or as many healthcare workers and first responders vaccinated as soon as possible. That has got to be the priority because right now, our hospitals are slammed with COVID, and we're not only having bed shortages, not having enough room to house the patients, we're having staffing shortages. People are out because they're on isolation or quarantining appropriately, and it's making it difficult to take care of the patients who really need it. Even in my office, I'm having to send nurses or what have you home because they're positive, and then we're limited on the patients we see, and we're seeing the well and the sick, of course, outside. We're screening and testing patients every day. And it's very difficult to keep up because if I can't, for instance, see the sick patients and try to keep them away from the hospital, they're going to the hospital. They're going to the emergency department and increasing numbers there and increasing risk of exposures. But making sure we can convince, especially our nurses, our respiratory therapists, our other, non-medical, not the physicians, but other staff and our first responders to get vaccinated is essential. And I think on top of that, the next group is definitely our most vulnerable, the nursing home and their workers, because we've had a lot of hard-hit nursing homes in our area where everyone but 2 staff members were out at a time, for instance. And if we can't convince those nursing home workers to get vaccinated, we're still behind the 8 ball. But I do agree with the way the CDC has set up the phases. I really agree with it so far. I think it's going to get wonky once we get to phase 2 and phase 3, who really qualifies, especially those who are eager to get their vaccine. I've already had some patients saying, hey, do you think I'm going to qualify for phase 2 based on my medical condition, even though I'm, for instance, 40, what have you? So some are going to be eager to get it, but we really got to make sure as many people in phase 1 in general get vaccinated. And that's going to be, I think, nationally, but we have to take it on an individual role, like individually as physicians, especially primary care physicians. I find it, it's a huge burden, a huge responsibility for PCPs to make sure our staff and our patients hear from us a clear message that this vaccine is safe, this vaccine's effective, we need it to do our job, to get to any sense of normalcy to control the pandemic.
Right.
Yeah.
Dr. Dawkins, I want to draw you into this conversation now, knowing that you're the only non-clinician, if you will, on the panel. So we'll deal with that. But I want to get your take on that last question that I asked you about the guidelines from your perspective, from your work and everything that you're doing over at Wake Forest Baptist, what you think about the guidelines, and should there be a social vulnerability factor in the vaccine rollouts? So please address that.
Okay. Thank you, Franklin. And I appreciate, again, the opportunity to be able to share today during today's Power Hour. I would like to read, so I reached out to one of my colleagues. So like Franklin said, I'm a PhD in orthopedic surgery. I am the program manager for an orthopedic residency program. So a lot of the what I visualize as far as the rollout is from a provisional perspective, kind of on the sidelines. But at the medical center, I have received several emails from internal communications from senior leadership about the vaccine, about it. We received an email saying it's coming. We received an email saying you need to sign up for the system, have the option of agreeing to get the vaccine or not, because I am, I guess, considered a non-essential worker. I'm further down in the stratification template, but I do like the template because I agree that the healthcare workers, those who are on the front lines, definitely need to be able to get the vaccine. And so I'll, if you'll pardon me, I want to read what my colleague said. I reached out to him because he is in the know about the COVID-19 rollout for Wake Forest Baptist Health. He said, currently the vaccine we are receiving is to be given to our employees who are higher risk. We will soon start offering 1B stratification vaccines in our offices, including the Downtown Health Plaza. So the Downtown Health Plaza is a Wake Forest Baptist Health facility that's placed within a predominantly African-American section of the city. There is to be coordination with Novant Health, which is another health system that's within our area. And what I do like about this pandemic is that there are several health systems that have collaborated and have been on a united front as far as addressing the pandemic, even regarding elective surgeries and addressing things like that. So there's to be coordination with Novant Health for some community events, but we were to go to the patient base, including Downtown Health Plaza and some other underserved clinics next. The health department is supposed to be coordinating community events. Walgreens and CVS are providing vaccines to residential community establishments. And plus there's a town hall meeting today that's going to offer more information to Wake Forest Baptist employees. So I do agree with the stratification system, and I do like the rollout plan. Listening to Dr. Smith, sometimes there is maybe a gap between how you're designated and how that's rolled out. So that those types of inconsistencies definitely needs to be worked out. I do think that the social inequalities should be considered. I think one thing that COVID-19 has showed us is that the same communities seem to be negatively impacted with all these different occurrences, so we can't ignore it. But we definitely want to make sure that the healthcare workers, those who are on the front lines, those who are there, who are exposed consistently, definitely need to have the vaccine. As far as getting the vaccine itself, I am a little bit of distrust or mistrust, and I'm a little bit of hesitancy, and it is because of my perspective as an African American, and it's also because of the quick rollout, and because there's limited data. But I think that the more that I see that people are getting the vaccine, I'm kind of following all the information, and perhaps my perspective will change a little bit. So I just want to kind of see how things are going and kind of keep up with things. So that's how I would like to respond. So thank you.
Super. That's completely understandable. Thank you for that viewpoint. Dr. Murphy, I do want to come back to you with that same question about the CDC guidelines that we're currently operating under, and the question about social vulnerability being included in those metrics, and how you view those, number one, and how maybe you think UNC and that health system views that.
Right. So I think that the system, the guidelines they make sense. And it gives you some way to kind of stratify and at least, give you a plan. So I do agree with that. The challenge that we have had, and I'm sure others also, is, what's really a 1A, 1B, and so forth. Obviously the front care, the frontline healthcare worker who's there actually at the bedside, obviously they get priority. But then once you move one step down and start to talk about, say, the transporters in the OR or the housekeepers and those people who definitely have some form of patient contact, where do they fall? And then, even once you take one step back, I know in our department, we have a receptionist who is kind of down near the OR. She's one of the administrative staff, but clearly interacts with us every day. Occasionally people may come into the office. So by the classification system, she would clearly not be in the 1A area, but she, is down around patients. So unfortunately, those types of positions and those jobs are usually more often held by minorities. And so when the classification system becomes a little less defined or wonky, as somebody described, unfortunately, it seems like sometimes the underserved bear that brunt. And so I think that the classification system works, but there are some areas where we really need to examine, who's falling between the cracks.
Mm-hmm. Super. Okay, guys, we're about halfway through, so I want to pivot now to the second part of our discussion today about the distrust and the reluctance that we've kind of tippy-toed around a little bit, and particularly as it addresses different communities. So we know we've got a long history in this country of Americans and Native Americans being mistreated by various and sundry institutions, and we got to get beyond that, clearly, okay? So I'd like to go around with a panel and speak about your experiences within your institution and practices, Dr. Smith, that you've seen or witnessed some of this mistrust in the medical infrastructure that now rolls over into the COVID-19 vaccine. So that's the first part of the question. And then the bigger part of this question is going to be what we're doing at your various and sundry levels to overcome and battle that mistrust. And Dr. Dawkins already talked about her trepidation a little bit there, and she's kind of, making some progress there, which is kudos to you. But Dr. Murphy, since you're right there, could you take that question first, please, sir?
Sure. There is distrust. I think some of it is due to just the media. And, I think all of us have a little bit of confirmation bias. And so you read news stories, you look at Twitter feeds that will help kind of reinforce your worldview. And so I think that there is a lot of information, and sometimes it's hard to really filter out what's true, what's not true, and, to help you come up with an informed decision. And unfortunately, a lot of the information that's out there isn't from, the New England Journal or Lancet, or, it's, other places that may be not as reputable. And unfortunately, the other part that leads to mistrust of this is the politicism of this whole issue. I mean, there is the fact that it was rolled out quicker than other vaccines. There is the fact that we don't have the long-term data, but then once you lay the politics on top of it, I think for a lot of people that has just been really hard to sift through to get to the real answers. So it's challenging. I think it's very challenging for especially us as African Americans who have had this longer history and just are distrusting overall. So the way that I choose to really help people through this is two ways. One, I'm a vaccine advocate. I think that for those of us who are working directly beside these patients, I think I describe it as an extra layer of protection. If I go in the room, I'm going to put on the goggles and the mask and the gloves and those things. And to me, the vaccine is just one extra layer of protection. And also, we get to see the true consequences of COVID disease here where I work. And so the way I talk to people when they, ask me how I feel about it, I can just give them a direct comparison. I can say, you saw this patient that had COVID, look at those complications versus some of the theoretical risk associated with the vaccine. And so I think just having that direct comparison for somebody to actually see, at least I think that helps me sometimes when I'm, asked the question about why and how and when. So that's just one strategy I use to try to convince people or talk to people about the merits of the vaccine.
Super. Dr. Brooks-Locklear, I want to come to you next, and I want you to talk about it from your perspective, both as a family physician with your institution down there, your area, the state, and also as a member, as I understand it, of the Lumbee tribe, right? And how maybe you guys have looked at this and how you're overcoming it as a tribal nation down there. Thank you.
Yes. Yeah, so I'm a member of the Lumbee tribe, which is a Native American group. There's many tribes in North Carolina, so I don't claim to be expert on every tribe. I would like to think that the North Carolina tribes have more similarities than differences, though, obviously. And I've tried to be an advocate amongst my community. It's funny because the tribal chairman happens to be my long-term patient. And so he and I have done several videos throughout the pandemic to try to educate specifically our Native communities from the beginning. We've probably done maybe a dozen. I'm trying to educate them on the numbers and how to protect themselves because we've been hard hit. It's funny because our Robeson County numbers have a breakdown of the racial numbers of COVID cases, and we're extremely high, the highest week after week after week. But I would have to say, when I really think about it, I don't feel like we as a Lumbee tribe have a specific racially based hesitancy for this vaccine, unlike definitely my Black patients, amongst the Black community, obviously understood. However, there's just this huge vaccine hesitancy or clearly a resistance. And you hit the nail on the head, Dr. Murphy. Don't get me wrong, there's issues with the quick process, the unknowns of long-term side effects, the new technology, the mRNA. There's a lot. The average public obviously does not understand this technology, even though it's been around for decades amongst the scientists. But I really feel like our nation's political polarization is clearly evident in my Native community. Unfortunately, we're completely at odds. It's like a 50-50, in fact. It's like half our population believes one thing and half our population believes another thing. So this pandemic has created huge, vast opinions about this vaccine, about anti-mask theories, about faith over fear. I mean, many ideologies, but that, of course, evolves down to this vaccine. And so there's many people who have associated so much distrust with science and medicine during the pandemic. And a lot of those people do not plan on getting the vaccine, unfortunately. So I see it all the time. I talk about it with every patient for regular follow-up visits. And now once the vaccine the first vaccine was approved, I've made a point to bring it up to my patients. So especially my patients 60 and older, I make a point with every follow-up visit to talk about the vaccine. I purposely bring it up no matter how difficult the conversation is. And the things I found is, number one, there's hugely a benefit when the physician's a person of color and your patient's a physician of color. So probably half my population is Native American as well. probably about 40% is African American, and maybe 10 or under is probably white. Okay. So majority of my patients are people of color. And then majority of my patients I've had for many, many years. I've been 10 years in this office, and you have a very long, trusting physician relationship. I find that if I'm having a conversation with my patients, they're going to, what I say does have more validity than just what they're reading maybe in the news. I'm able to convince a lot of people. But I find that if I'm being very personal, I'm telling them the reasons why I'm getting vaccinated. I'm very vulnerable. I'm honest. I tell them how, hey, I see COVID every day. I have many positive COVIDs a day. I need to protect myself. I'm protecting my family. I'm protecting my community, and explain why. They seem to get it when I just give a little 2-minute spiel, as Dr. Smith said. I find in our community, there's 2 strong ties that I use to try to nail it in with the patients. One is our faith, our Christian faith, the church. And number 2 is our honoring of the elderly. So I always bring those 2 points in, that science is basically a gift from God. And most of my patients would agree with that. And I talk about how the beautiful thing about these vaccinations being so effective is essentially a miracle. And God has given us the miracle of science to protect us, to navigate the pandemic. And I explain the importance of protecting yourself, but also me protecting me prevents me from getting my patients sick, right? I am first to do no harm to my patients. I don't want to potentially get my patients, my employees sick in my office. And me taking a vaccine is helping the greater good. And once they understand that it's not even just my personal decision to help me, it's a decision I'm making for my community, for my patients, for other people. That kind of, that really, I think, gets them to understand the bigger picture of why we need herd immunity and why we need people to be vaccinated. And then, of course, I bring in the importance of protecting our elderly. They're the most vulnerable. They're more likely to be admitted to the hospital, suffer complications, obviously. Begging them, they need to protect the elderly themselves. They kind of get that. And so I've been really talking about the last 2 weeks with the rollout now with the 75 and older with the initial phases, and have been able to convince several of my patients the past 2 weeks to sign up to get their first vaccine as far as the public's concerned. And I think it's been very effective if I just sit down and talk to them. So even people who first said no, after I talked to them maybe 2-3 minutes, I've convinced most of my patients to get the vaccine. And so you have to understand they're going to come in with many, many biases and conspiracy theories. But if you really sit and talk to them, I'm able to convince most of my patients. You know, you just got to find that sense of commonality to sit down and talk to them. But so far, it's been very persuasive. And so I continue to try to plan to keep it up in the future, you know.
Super. Thank you for that. Dr. Dawkins, I do want to come back to you since you've got a little personal story that you started to share with us about this question, but also speak about what's going on in your institution and in your work.
Thank you for that question, Franklin. I like what Dr. Brooks-Locklear brought up, which demonstrates the importance of having physicians that look like the patient population, because using faith, because faith is hugely important to folks of color, particularly, and so to utilize that in your practice and to know how to do that is very important, and it just speaks to the importance of why we need to ensure that there are no barriers to physicians of color coming into the practice. So, but I think the huge thing, but mistrust is like the elephant in the room. It's been there for years, for hundreds of years, the mistrust. And it's based on history. And it's, sometimes we don't really examine the consequences sometimes when we talk about this discussion, but if you talk about the Tuskegee experiment and the other research experiments, so if someone is sterilized, that cuts out their ability to have children. And not only is it that aspect of not being able to bear children yourself, is the emotional impact that it happened and you weren't aware of it. And then it's, of course, if that happens to you and it's in your family, that's trauma. that you can't just dismiss. And it's generational, because if it happens to you, of course you're going to tell your family, and you're going to communicate the mistrust. And also, some of these things, it wasn't that long ago. And also, some of the same facilities who committed some of these atrocities are the same ones who are telling you to come and get the vaccine. So I think we have to deal with that. We kind of have to fully acknowledge the mistrust and just examine it. The things happened. We were a part of it, whatever that looks like, and then start to build those trusting relationships. And trust, it takes time. It takes time to build it. And it may be that some of those walls that were broken down may not be able to be built back up. But I think the pandemic is making us deal with that. And now we're seeing how far reaching it is. And so I think that once the healthcare industry is really intentional about building those trusting relationships, and not only just letting it be what is said, but also putting processes and procedures in place so that these violations don't happen again. And also institute methods of accountability. Who is making sure that there are no instances of mistrust, that there's no instances of mistreatment. And so I think if we fully have those kinds of discussions, I think we can see a little bit more, I think we can see a decrease in hesitancy for taking the vaccine. As far as my institution, again, I like the way it's been rolled out. I don't really get a sense that there has been any negatives in the process. Again, I'm not in the weeds. Since I'm not a clinician, I definitely have a different vantage point than, Drs. Murphy or Dr. Smith and Dr. Brooks-Locklear. And so I really do like how the medical center is rolling it out. I like their transparency as far as this is the status of the vaccine. This is the process that we're taking. These are the people that are included. This is the system that you need to sign up for, and it has information, it has FAQs. So it's taking a very educational approach and a very intentional approach about keeping all of our employees kept abreast of what's going on. So I really appreciate that. I appreciate the collaboration within the city, because it just makes sense, and it helps to get the word out about the good things that are going on, and the intention and the focus on getting everyone vaccinated that needs to be.
Super. Thank you for that. Dr. Smith, I want to come to you now. Again, and your perspective is going to be a little different because you're in Raeford and, you've got your private practice. But I know that you play a key role down there in Raeford in encouraging people to do the right thing where it comes to healthcare, at least. And so I want you to talk a little bit about this question and what you're doing specifically in your community.
Thank you. It really has been a challenge. And I agree with Dr. Dawkins because healthcare are often the culprits who have created some of that mistrust, or quite a bit of it. Let's talk about the management and treatment of COVID and patients who are hospitalized. So I had a patient who was on dialysis, and I spoke with the hospitalist team, and I asked about remdesivir. I actually had her family members sitting there with me in the office. The patient was in ICU, and the physician said she is not a candidate for remdesivir. She doesn't qualify because she's on dialysis. Well, I've read that and it says remdesivir is safe in chronic kidney disease patients on dialysis. This is in the literature. Yet the management of the patient was it contradicted the literature. And the patient died. And so this is the mistrust that we have actually generated. We look at our mistrust that has been generated from our own capital, our own Washington, D.C. And I have patients who come in and say, I'm not getting that vaccine. That's the president's vaccine. He created it and made it so fast. and you want me to take that vaccine? And so the messaging is inconsistent. We have our anti-vaxxers who have jumped on the Trust campaign, and they put out all kinds of things, Bell's palsy, sterility, everything else. And so we're having to go back and try to tease all of this apart. And that's where I said, what can I say in 2 minutes time that will convince you and get rid of some of the distortion and fact that has been put out there? I absolutely agree with enhancing the cultural values. And so in our community, one of the things that we did was look at the CDC website, and it had a wonderful project that was done with the beauty shops and the barber shops in regard to getting the information on HIV and encouraging people in the community to be tested in HIV. But they used that communication through the barbers and the beauticians. And quite frankly, I trust my beautician. And so do some of the people who I see in my community. But it worked. And it allowed people to get tested for HIV and to know what their status is. So we actually took the same approach for the COVID-19 vaccine. Likewise with our elderly population. And so we had a picture, I didn't know if we could show it or not, of our oldest couple in our practice, 96 and 94 years old. And they had been married for 75 years. And they were actually put on the front page of the newspaper, where that was the couple that I asked, will you please get the COVID-19 vaccine? And they had 2 scares in their family. And of course, Mama and Papa said, oh yes, we will get that vaccine. So at 1 o'clock today, they're at the Hope County Health Department to get the Moderna vaccine. We recognize that once the elders get the vaccine, and the kids start to see the example in the different families, which we have large families in our community, and everybody starts to see if mama and daddy could get that vaccine, we're going to get that vaccine. And we also put it out with the Civic League, which is the organization where all the churches communicate. But we put out the information that opposed what has already been on Facebook and all of these different distorted facts to instill the trust to please get the vaccine. The last thing that I was going to say while this is my favorite couple. And you could tell Mama is serious about the way life should be. But one of the things that we're getting back is that people are saying, Dr. Smith, when are you going to get the vaccine in your office? I want to come to your office and get that vaccine. And I see that we have our board chair for the North Carolina Academy of Family Physicians is listening in, Dr. David Bryant. And the Academy was so convincing and put out wonderful information that we now know that our own Shannon Dowler with North Carolina Medicaid is working to get that vaccine into the private physicians' offices so that we can give the vaccine. And when patients come in, after I give my little 2-minute convincing discussion, the next thing is to give them the vaccine. They don't even have time to think between my office and the health department because we're going to give them the vaccine before they walk out the door. So that's what we're doing. And I hope that I encourage all of our providers to go online, sign up, get registered so that you can give the vaccine in your office if you have that capability. It's in a community setting where we're really going to make a difference.
Super. Love that picture of your patients. That's great. We should share that with everybody. We have about 3 questions I want to read to the group. So it'll be kind of a toss-up from our audience. Hello, my question is, with so many people getting sick with COVID and recovering, what would you tell people to gain trust of getting the vaccination after having recovered from COVID-19? Dr. Smith?
Can you repeat the ending part of that question, please?
Yeah, it said, what would you tell people to gain trust of getting the vaccination after having recovered from it?
Well, you know, there's the answer. You recovered.
Yeah.
One of those people who survived.
Yeah.
And we do see that there are variations of the COVID or coronavirus coming out, and we need to get you protected. And that's literally what I say to them. Some of them are fearful, and they will respond and say, you're going to put in my body the very virus that almost took my life. And then we go in and we give the science explanation. And then we also give that explanation. And not only do we want to protect you, We want to protect your family and everybody else who you come into contact with. But you lived through coronavirus. We don't want to take that chance again.
Perfect.
Franklin, if I can echo on that too. I mean, I think there's a perception that if you get COVID, you will recover. You know, you see celebrities and other people, you know, you can go down the list of people who had it and talk about their stories. And, you know, so I think there's a perception that, oh, I might just get it, but I will be fine. And when I talk to people, I say, yeah, there is a chance that you will be fine unless it kills you. And so you know, you have to have those talks. You have to have those, you know, one-on-one, spend the time with people to educate them, because there is a perception that, you know, coronavirus is not that big of a deal and you can get it and, you know, 2 or 3 weeks later, you'll be fine. And we know that's not always true.
Right. Dr. Murphy, while I've got you, I wanted to ask you, in switch hats, you're, you know, the president of the medical board. What is the medical board, what is your position on the vaccine rollout? What are you guys doing from a board position to support it? Any nuggets there that we need to know about?
Well, I will apologize and say that I am no longer the president of the medical board. I'm actually the immediate past president. So
okay.
I'm sure that the board is working on something, but I unfortunately don't know exactly what it is right now. So
Okay.
Sorry about that.
Nope, it's my fault. Okay. Dr. Brooks-Locklear, I want to come back to you and give you a chance to answer this question about that we've just been talking about with Dr. Smith and her patients. And Dr. Murphy, tell me what your thoughts are.
Yeah, I would say 2 points to that is number one, making sure patients know they can become reinfected. It's happened to a couple of my patients. I've had to tell them they've had COVID twice. So making sure people know that their normal natural immunity is not permanent, and we never know how long it's going to last. There is no way to say. And I try to tell people you may have a honeymoon of a couple of months, but there's no guarantee. So just because you've had it once does not mean you will never get it again. And so I kind of tell everybody that actually when they're positive. When they're positive, I tell them, hey, you better be very careful. Don't assume, because I don't want you to be one of my patients I've had to tell they've had COVID twice, and usually the second time was worse. But the second thing is I'm trying to tell people, even if you are blessed enough to live from COVID, that does not mean you're normal. We know there are so many potential long-term complications. There's so many long-term sequelae. We're learning some, but there's many to be learned as of this point. I mean, even amongst college athletes, what was it, 30-some% have heart damage, have myocarditis amongst healthy college athletes. I have patients months after COVID still have coughing, fatigue, brain fog, shortness of breath, who were disabled for months before they could go back to work. So forget about the 10-day isolation period where you're no longer infectious. COVID can last in your body for weeks or months. Actually, I'm seeing it more in my 40 and 50-year-olds. My 70 and 80-year-olds who survived COVID actually, to me, seem to bounce back more than my 40 and 50-year-olds. So trying to explain that to people that, you know, it's not something that's a minor illness, a minor head cold you easily get over. You never know how it's going to affect you. So you should make sure you try to prevent another infection. I think some people don't understand the long-term effects. There are some that have suffered through a severe bout of COVID who know that they never ever want it again. They know they're going to vaccinate themselves, but others who may have had a mild course just assume it's okay and no big deal. And I try my best to educate as much as possible. You need the vaccine to prevent a potential long-term problem. I don't want to get COVID because even though I'm healthy, I don't want it doing damage to my body months from now, a year or two from now, I find out there was a problem, you know? So I think making sure our patients understand the long-term sequelae is vital to helping them understand why it's so important to prevent it to begin with.
Okay, super. Dr. Dawkins, I don't want you to feel left out about that question. And your work is so important at Wake Forest Baptist. So the question I guess I'd have for you around this particular topic is, what are you willing to do within your range of influence to help overcome the mistrust and get people to, you know, get vaccinated and move this thing forward?
Okay, so you're putting me on the spot, Franklin, because I'm slightly on the fence.
I know. That's why it's called the power hour.
I see. I see. Yes, I'm about to demonstrate my power. I'm just going to continue to watch what's going on and read more, because I have been seeing more things. I've seen different programming, media programming, where they're demonstrating those who are getting the vaccine. And because I am in healthcare, because there was a thought in some communities, as we've progressed through the pandemic, that it wasn't real and certain people couldn't get it. But because I'm in healthcare and I see the emails, and because I manage a residency program and I see how the typical schedule for our orthopedic residents was significantly changed for about 4 to 8 weeks, then I know how real it is. I know people that are involved. I have colleagues across the system that are on the front line, some in the ER, and I hear them talk about it. So I think I'm just going to continue to stay plugged in and watch things going on, and probably not be so quick to talk about opinion, but kind of just get more in the data and just let that sit with me, and having conversations about this, especially with you, Dr. Brooks-Locklear, about just all that really that you all have shared as clinicians. It really has given me more insight. So I will definitely stay tuned, and but I want to wait until I get to a point of feeling comfortable before I share with other people, because I don't want to be insincere also. And I do have aging parents, and because there doesn't need to be any more insincerity and being disingenuous. But I definitely am moving towards seeing the positive aspect of having the vaccine and getting as many folks vaccinated, especially with I was listening to the news, this new strain that is spreading across, that's in the UK already, is more contagious. So I know it's even more important for this vaccination.
Well, yeah, that's great. I want to read something. I don't know if you've seen this yet or not. Dr. Rachel Keever, who's a frequent participant or listener to the Power Hour, has chimed in and said, my new talking point for vaccination for patients dying of COVID, the average loss of life is 13 years. That's a pretty strong statement. But anyway, Dr. Smith, I do want to come back to you. This is going to be our final wrap-up question. 10,000 new patients yesterday in North Carolina, all-time record. ICUs are getting full. Winter has set in North Carolina. What are your plans for your practice in your community to get through the next several months, knowing that even though you and your practice folks may be vaccinated, what are your plans to try to get through the next couple, 3 months?
Major plan that we have really did come from the advocacy work of the Medical Society and the North Carolina Academy of Family Physicians and the pediatrics and all of our associations. And what they did was to advocate to our secretary the need to allow the private physicians, the independent offices, to now be able to have COVID-19 vaccine in our offices, so that we can really move and get to that 20 million point of vaccination. And so we're putting a lot of effort into that and into our community. I really am concerned with the business model, yes, but I'm also concerned about the loss of life, and recognizing that we need to do something to change that trend. I also sit on the Scarce Resource Allocation Committee with our state, North Carolina Institute of Medicine, and we're concerned that we are going to run out of resources for people who need them in the critical care setting. We've already talked about our hospital personnel as well as our outpatient physician activities. And so we really need to change that curve, get folks vaccinated, and let the community doctors be part of the process and take care of those community doctors as well.
Certainly. Dr. Murphy, I want to come to you. from your perspective on this from UNC's healthcare system. Also, adding to that, we had a discussion on Power Hour a couple of weeks ago with emergency physicians from across the state. And one of the folks was a doctor at UNC Rex Healthcare who is, she's in the emergency department, but oversees it from a system level, and talked at great length about the nursing shortages and the burnout and whatnot. And Dr. Smith had mentioned something about workforce. So as you talk about what maybe the system is planning, can you address what you're seeing in the nursing ebb and flow of that workflow? And is the possibility of having the vaccine come back into play, helping you guys overcome that workforce shortage?
I mean, from a big system standpoint, I mean, we're planning, we're waiting, we're watching, we're responding. We have hundreds of absences per day with COVID-related absences for various reasons, either people with COVID disease, people who have been quarantined because of exposures. And so it's always a fairly big number. The hospital is always usually almost at capacity. And so we also spend a fair amount of time and resources supporting our system hospitals. So transfers, ICU admissions, different things. And so, like I said, we plan for the worst, hope for the best. The vaccine program, like I said, I think that will help. Having this on the tails of a national nursing shortage really didn't help, but we're working through that. And, we do have some other contingencies that we can do if we need to. I mean, we talked about, how do things that we talked about earlier in the year, like elective surgeries, how do things like that play into these equations? And so we're just, day by day looking at the numbers, looking at the trends, and making decisions based, on the ground based on what the conditions are.
Super, thank you. And finally, Dr. Brooks-Locklear, want to hear from you on this subject and what's going on down there in your neck of the woods.
Yeah, so we're definitely preparing here locally. So for Scotland Healthcare System, we're making plans in the hospital side since we're about maybe 95% capacity. So that means making new rooms out of OR holding rooms, or turning the women's GYN rooms into COVID, medical floor. We're trying to change up how we do inpatient surgeries and cutting that back to accommodate for the COVID surges that we're seeing. So we're making a lot of changes with the help of our CMO in the hospital side. And as far as our office side, I've seen personally crazy uptakes in our clinic numbers. So more and more people are coming in for testing. So we're trying to figure out ways to accommodate our schedule, like how in the beginning we tried to do, for instance, more of the telehealth visits. And then we were stable and did way more regular in-office visits. And I'm learning that I'm going to have to probably try to go through my schedule again and figure out my chronic follow-ups to see who can be a telephone to limit their exposures in the office, to also allow a little bit more room in my schedule to accommodate the sick visits, since I'm seeing so many people coming in for testing. So it's like the hospital and the offices are making changes to adapt to these surges. And like what Dr. Smith said, we're actually starting to do the vaccine on the 11th, come Monday, in our offices. And so you hit the nail on the head about the patients, because some of them trust maybe me, but may not trust the healthcare system at large, right? And they're saying, well, I'm gonna come and get my vaccine if you give it to me, if your office does it. And so we're trying to also figure out a way to truly manage that, to be honest. There's a lot of logistics to doing the vaccine in an office. I mean, with the staffing and making sure you have the amount of people on the schedule for the doses in the vial and you don't waste the vaccine. It's a little tedious. And so we're going to try to figure all that out next week. There are some experts at the hospital helping us to navigate that, because we're hoping we can get more people in the community, the 75 and older, vaccinated if they do come to the office. But just meeting these strategies to try to help. We think that the worst is yet to come, and the numbers will probably keep going up over the next month or so, unfortunately.
Thank everybody for being part of today's Power Hour, and thank you so much for doing what you're doing in your areas of influence in North Carolina. Happy New Year, and we'll see you on the next Power Hour in 2 weeks.